Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Hello students, and today I bring to you a case of heart disease in pregnancy. This is a very important topic in terms of at your level. Why? Because the questions are asked from the undergraduate level. A lot of those questions would be asked from the undergraduate level. For example, the complete examination of heart will be asked to you right from inspection to palpation to auscultation. And when you're talking about auscultation, all these areas like mitral area, tricuspid area, aortic area, the different kinds of murmurs, how to measure the JVP, all these things I strongly recommend go back to your basic books. Like even I did that before preparing at the time of preparing for case presentation for the cardiac disease. Go back to your basic books, read the basics, read all about the examination, the inspection, palpation, auscultation, all these areas, to be wiser for listening to this this case discussion. Because once I speak and then you go back and try to recollect it, you'll find it very easy. You'll feel as if you know everything. But if you do the other way around, then you'll understand your lacunae, because I'm giving you one side of the whole thing. But when you see the entire stuff that can be asked, so many things, parasternal heave, thrill, where should the apex beat be, how does it shift in pregnancy? So these, normal physiology and the physiology of pregnancy both get clubbed together when you're talking about cardiac disease in pregnancy, and which is why this is a very difficult case. And everybody wishes they do not get cardiac disease in pregnancy. Apart from that, whenever cardiac disease comes, it is very vast. It can be about your Viva can go on the valves. You can valvular disease and valve replacement. Of course, it can go to your anticoagulants, their half-life and everything. It can come to congestive cardiac failure. It can come to cardiac arrest, troponin levels and stuff. And it can also go to the fibrillations, the arrhythmias. So that is why it's very vast, and I'll do complete justice with it. I'll take as many parts as possible to cover everything, and all those basic and high level questions, so that you're able to prepare both ways. Because if you fumble in your undergraduate Viva, you will not be putting a good impression on the examiner, and that could be a reason for you to flunk the practicals, which obviously you do not want. So let's begin with the case without wasting any further time. My patient, Mrs. X, 28-year-old female, wife of Mr. Y, 32-year-old male, banker by profession, resident of so-and-so place, is a primigravida with LMP so-and-so and EDD so-and-so, with previous regular cycles, making her POG around 24 weeks, is an unbooked female and known case of rheumatic heart disease, who came to OPD with complaint of dyspnea on exertion and palpitations since the past 1 week. As per the patient,
excuse me, doctor. What are the causes of dyspnea in pregnancy?
The causes of dyspnea in pregnancy are, first of all, it could be physiological dyspnea in pregnancy, which happens because of the, increased effect of progesterone and advancing gestational, age, with the fetus pushing on the diaphragm and you feeling a little hungry for breath. Number one. Number two, anemia in pregnancy can cause similar symptoms. And third and most important is cardiac disease in pregnancy of varying kind. It could be congestive cardiac failure. It could be, valvular disorder because of RHD, like our patient, and because of which any reason because of which the heart is not able to meet the physiological demands of the pregnancy, the growing pregnancy. This could be a reason. Of course, physiology is a very important thing. That as the growing fetus is there, it's very difficult for anybody to pick to maintain the normal activities sometimes, and you feel dyspneic even on normal physical activities. So these are all different differential diagnosis. So history of presenting illness. As per the patient, she's a known case of rheumatic heart disease, diagnosed somewhere at the age of 12 to 14 years. She doesn't remember, and was apparently all right in pregnancy till date. Her previous ANC was elsewhere. But he started to complain of difficulty in breathing and palpitations on climbing one flight of stairs since the past 1 week. There were no issues, there were no complaints on climbing the similar flight of stairs before this 1 week. She does not give any history of breathlessness while walking or lying down or doing normal household chores. This breathlessness is associated with palpitations which are insidious in onset, gradually progressive, and relieved on rest. There is no history of any similar episodes in the past. There is no history of any syncope, chest pain, cough, hemoptysis, or swelling on the face, though she is noticing pedal edema more than before. There is no history of bleeding PV and leaking PV, fetal
Okay,
movements.
doctor, can you tell me, please elaborate the relevance of negative history here?
We are trying to find out what could be the reason of this dyspnea and which she's having right now. So we're trying to associate it with maybe she's having some chest disorder, like for example hemoptysis with cough. That means she's having some congestion in the lungs which is making her breathe this way, and she's not able to have a complete breath, and she's having this breathlessness, or any history of any kind of infection in the recent past because of which she's having this congestion in the chest, and because of which she is having this problem. Syncope, chest pain, that means something to do with heart. That means if she's having some disorder in the heart, that means that is the reason why she is. Something can be also, or secondary or associated along with rheumatic heart disease, or the valves which were already affected because of RHD. They were earlier fine with the previous pregnancy, but now those valves are not able to handle the stress any further. For example, she might be having mitral stenosis, which was kind of compensating up till now, but as the demands are increasing of the pregnancy, as the pregnancy is growing, it's not able to sustain the demand because of the stenotic valve, and it's not able to pump as much as blood as is required, especially during strenuous activity. So we need to find out what is exactly the cause, and whether or not she's having any swelling in the face, because that is again associated with one of these, mostly because of an affected renal profile, which is actually not directly associated, but yes, if she's having basic congestion in the body, that means this could be an after effect of right or left, especially right ventricular failure. So these are all signs to show that whether her heart, her lungs, all those vital organs which are responsible for her proper breathing or breathlessness, if they're not okay, they're associated. This is the reason why we take a negative history, to just delineate the cause through the history. Now, history of presenting pregnancy. First trimester, it's a non-consanguineous spontaneous conception. Patient detected the pregnancy by home UPT and confirmed it by an ultrasound, which was done 1 month later. She was showing to a local gynecologist. There is history of folic acid intake. There is no history of any excessive nausea, vomiting. There's no history of any fever with rash. No history of any radiation exposures, and all investigations which were done in first trimester came out to be normal as per the patient. Second trimester, quickening at around 5 months. She was taking iron and calcium regularly and also received 2 doses of tetanus toxoid. Blood investigations and ultrasounds done till date are all normal as per the patient. There is no history of leaking and bleeding PV. Fetal movements have been perceived fine. Patient is giving no history of breathlessness or chest pain, palpitations until the last week. Menstrual history is normal, regular periods of cycles of around 30 days, coming of 3 to 4 days, coming at a gap of around 30 days. There is no history of any dysmenorrhea. LMP was so and so, making it the EDD so and so. There is no history of any, that will come in obstetric history. Married for 2.5 years. She's a primary gravida. Husband was away for around 1 year. And there is no history of any contraceptive use, and this was a spontaneous conception. Past history, she's a known case of rheumatic heart disease, which was diagnosed at around somewhere between 12 to 14 years, and patient does not remember the entire episode clearly. There was no other relative to take the history from. There is no history of any diabetes, hypertension, or TB. There is no history of any recent or past surgery in the patient. Family history, there is no history of any congenital heart disease in family. There is no history of TB, diabetes, hypertension, or any genetic problem, any congenital abnormality running in the family. Personal history, patient is a non-vegetarian by diet. She consumes around 2100 kilocalories and around 66 grams of protein by 24-hour recall method, which are adequate for her build and height. Sleep pattern is normal. Bowel and bladder habits are normal. There is no history of any smoking or alcohol intake or any other illicit drug abuse. Patient is currently on antenatal iron and calcium supplements. There is no history of any other drug. Patient is a housewife belonging to the upper middle class and does normal household work, but she lives on the first floor with the kitchen on the ground floor, and now she complains of breathlessness, which is complicating her day-to-day illness. Summary: my patient, Mrs. X, 28-year-old primary gravida, 24 weeks pregnant, known case of RHD, NYHA classification 2, currently not on any medication.
Can you, doctor, just brief the NYHA classification of dyspnea?
So NYHA has 4 grades: NYHA class 1, 2, and 3. 3 and 4. So first is having no signs and symptoms. Class 2 is having very mild signs and symptoms on exertion, on normal physical activities or on exertion. Class 3 is having signs and symptoms even on mild or normal physical activities, and class 4 is severe symptoms even on rest.